Thank you.
So thank you very much, Cecilia, for that introduction and for inviting me to give this talk today. So we'll be reviewing amplitude integrated EEG monitoring in the cardiac ICU today, and I'm hoping for it to be interactive, so we have some polling questions throughout the talk as well. But before we get started with talking about amplitude integrated EEG monitoring, I just have no conflicts to disclose, and we'll review some of the objectives for today's talk. So we'll start off by reviewing the incidence of seizures in neonates with congenital heart disease. We'll review an overview of amplitude integrated EEG monitoring, the background patterns that we look for on AEEG, and then finally seizure detection on AEEG. So when we look at the incidence of post-operative seizures in neonates with congenital heart disease, an estimated 5 to 20% of babies will have clinical seizures post-op, and 5 to 25% of neonates will have subclinical seizures post-operative in the post-operative period. And this is really why EEG monitoring is so important in this group. And 60% of the babies who have clinical or subclinical seizures will have status epilepticus. Seizures typically occur at a median time of about 20 hours post-op, with the majority occurring between 12 and 36 hours post-op. Seizures are important for outcomes. Seizures have been associated with higher mortality rate in this group and have also been associated with adverse neuropsychological outcomes, such as lower reading and math scores, poor memory, executive function, and visuospatial function later on in adolescence. And there may be some evidence to suggest that treatment of seizures in this post-operative period may be associated with less severe deficits at 4 years of age in this group. And so this is why detection of seizures is very important, so that we can treat them adequately. So these are the guidelines from the American Clinical Neurophysiology Society, and they recommend CEG monitoring after neonatal cardiac surgery because seizures are common, they're often subclinical, and they are associated with worse neurocognitive outcomes. However, this isn't feasible in all of our babies to use CEEG monitoring. And that's why amplitude integrated EEG monitoring is a very helpful tool for monitoring the newborns who are at higher risk for seizures. So I believe Dr. Han had given a talk earlier today about EEG and EEG monitoring in the ICU, so I won't go into this in too much detail. But essentially, EEG is a tool that we use to measure the electrical activity of neurons in the cortex of the brain. This is an example of a standard neonatal EEG display where we have many channels, shown here on the left. The blue represents channels that are coming from the left side of the brain, and the right represents channels recording activity from the right side of the brain. And then we also have some additional channels that we use in babies, such as the EMG electrodes to measure muscle activity. We also have a respiratory channel to measure breathing or monitor breathing during our EEG recording. And then finally, we also have an ECG lead as well. So as you can see, what we look at when we're looking at a standard neonatal EEG display is 15 seconds represented on one page. So this means that for a 24-hour recording, there's over 5,000 pages, and that becomes very challenging to review at the bedside. That's really why amplitude integrated EEG is so helpful, because it allows for us to monitor changes very easily at the bedside. So this is an example of the amplitude integrated EEG trace. And what happens is there's a vertical line that's generated every 15 seconds. And the top of this vertical line represents the upper border, which is the greatest distance between the peaks seen during that 15-second period. And then the lower end of that vertical line represents the lower border, which represents the smallest difference in peaks or smallest difference in amplitude that's measured during that 15-second recording. And essentially, at the bottom with your amplitude integrated EEG trace, you've essentially compressed hours worth of recording into a way that's very easy for us to see visually. So this is an example of what this looks like on a monitor in the ICU. So at the top, we have the raw EEG tracing that we saw earlier, where you have many channels. The blue channels represent activity from the left side of the brain, and the red channels are recording activity from the right side of the brain, and then the additional channels below. At the bottom, we have the quantitative EEG or amplitude integrated EEG. And here we have, once again, the same color coding. So blue represents activity from channels that are recording the left side of the brain, and then right represents activity from the right side of the brain. So this is just kind of reviewing that as well. Red is right and blue is left. So I usually remember R is red and right. So this diagram here compares conventional EEG to amplitude integrated EEG. And so from the upper panel, you notice a difference, which is the number of electrodes that we use in babies between conventional EEG and amplitude integrated EEG. So with conventional EEG, we typically use between 8 and 19 electrodes versus in amplitude integrated EEG, we use 4 electrodes. And this gives us a difference in terms of the number of channels of EEG that we have. So with conventional EEG, we have 9 to 21 channels versus in amplitude integrated EEG, we have 2 channels. And really, the use of amplitude integrated EEG has been a paradigm shift from using EEG as a diagnostic tool, where we have intermittent recordings and it's interpreted offline by neurophysiologists, to a tool that can be used to monitor brain activity. And it allows us to do this continuously. And there's a possibility for real-time interpretation as well. That's really why amplitude integrated EEG is a very valuable tool in the ICU. So in terms of amplitude EEG and seizure detection, with the 2 channels and simultaneous raw EEG, 70 to 75% of seizures can be recognized. There is a tendency, however, to miss some seizures that are focal or outside of the frontal, central, or parietal head regions, seizures that are low in amplitude, or seizures that are very brief. So ones that are less than 15 seconds can be missed. And the other important piece is that the amplitude EEG is vulnerable to artifacts. And we'll review some examples of artifacts later today as well. So these are the indications for amplitude integrated EEG monitoring in the cardiac ICU here at SickKids. So it's indicated in children for the first 48 hours post-Norwood procedure, for babies who are on ECMO, for babies with cardiac arrest or prolonged low cardiac output state, or for infants with a suspicion of clinical or subclinical seizures. And finally, when there was clinical interoperative concerns for inadequate cerebral oxygen delivery or prolonged cardiopulmonary bypass. So we're now going to move on to the AEG interpretation piece of this talk, and we will focus on 2 main things. So one will be to interpret different amplitude integrated EEG background patterns. And then the second part of the talk will be to review patterns that are suspicious for seizures. And we'll also review some common artifacts that we see in the cardiac ICU as well. So the AEG background pattern can be a useful tool in the neurologic prognostication of neonates with congenital heart disease. And in babies with congenital heart disease, a return to a normal continuous voltage pattern within 48 hours of cardiac surgery on cardiopulmonary bypass is suggestive of a reassuring prognosis. So when we look at the background, there's a key rule for us to remember, and this is the 5-10 rule. And this corresponds to the numbers that we should think of for the lower margin and the upper margin. So when we say lower margin, it corresponds to the kind of lower end of this thick bar. And that lower margin should be above 5 microvolts. When we say upper margin, what we mean is the kind of upper end of this kind of thick tracing, and that line should be above 10 microvolts. So here's another example that shows, So here's another example of a continuous normal voltage background tracing. This indicates normal electrophysiological brain function. And as you can see here from the diagrams, the upper margin of this thick bar is above 10 microvolts, and the lower margin of this bar is above 5 microvolts, and that's normal. We're now going to move on to another normal pattern, and this is sleep-wake cycling. So this is also characteristic of normal brain activity, and it occurs during continuous normal voltage tracings. And what you have is periods where the tracing is wider and then gets narrower, wider and narrower. So you have widening and narrowing of this trace, and that's called sleep-wake cycling. And you can expect to see one sleep-wake cycle per hour. So we're now going to move on to review some abnormal background patterns. So the first abnormal background pattern we'll review today is the discontinuous normal voltage pattern. So this is indicative of moderately abnormal brain function or encephalopathy. So in this pattern, you don't have sleep-wake cycling because that only occurs with normal patterns. And the key differences here is that although the upper margin is still above 10 microvolts, as you could see here, the upper line is still above 10 microvolts. The lower margin is now less than 5 microvolts. So this lower line, which you can see very nicely here on the right, is below 5 microvolts. There's also decreased variability, and the trace is very thick and broad. So here we have an example of another abnormal pattern, and this is indicative of severe abnormal electrophysiological brain function. And in this case, the upper margin and lower margin are both less than 5 microvolts. So you can see here from the diagrams, and we'll focus on the one on the right where it's very, very clear. The upper end of this bar is less than 5 microvolts, and it's the same with this kind of lower part of the bar. It's also less than 5 microvolts. And the reason why it's called burst suppression is that you have frequent bursts of activity, and this is very high voltage activity above 25 microvolts. And so you could see these lines, which represent the bursts, and each of these is more than 25 microvolts. And the severity of encephalopathy is associated with the number of bursts per hour, with fewer bursts being more severe. So here we have another abnormal pattern. This is called the continuous low voltage pattern, and is also indicative of severely abnormal brain function with very low voltage activity. And in this case, the upper margin is less than 10 microvolts. So you can see that here from the diagram, the upper margin is less than 10 microvolts. And the lower margin is less than 5 microvolts, which you can see here as well. Less than 5 microvolts. And then finally, the last abnormal pattern that we will review today is a flat or isoelectric trace. And this is the most ominous pattern. And in this case, both the upper and lower margins are less than 5 microvolts, as you can see here. If you look at the band, both the upper and lower margins are less than 5 microvolts. And you can see occasional brief bursts of higher voltage activity. So as you can see here, there are some lines indicative of higher voltage activity, but they're very brief, they're infrequent, and they're less than 25 microvolts as well. So there are a few things we need to think about when we see an abnormal background, and we refer to these as the 5 M's. So the first is mechanical factors. So for example, you could have poor impedance of your electrode that is causing a pattern that mimics one of these abnormal background patterns. It's also important to consider the maturation of the baby because preterm infants can have more discontinuity, and that is considered normal based on their gestational age. Medications can also affect your background. So medications such as midazolam, other sedating medications, for example, or anticonvulsants can change your background pattern. It's also important to consider inborn errors of metabolism and epileptic encephalopathies, which can present with certain background patterns, such as burst suppression. And finally, you want to consider medical emergencies. So acute illness can also change your background tracing, such as an increase in ICP and herniation can cause a change in your background pattern as well. So we're now going to move on to the more interactive part of this talk, and we'll start with our first poll. So I'm just going to launch the poll here. So we'll start off with question 1. So I'll give you a couple of minutes to answer this poll. Sorry, Cecilia, would I be able to confirm with you that you can see the poll?
Yes, I can see the poll.
Okay, thank you. So we're just going to do AEG background practice question number 1 for now.
You need to move the poll over a little bit so that they can see. Maybe it doesn't matter.
Yeah, I think it should pop up for them.
Yeah, no, they see the poll, but it's half covering the picture. But maybe it doesn't matter. Maybe it's not on their screen. Maybe it's only on mine, and I can move my own.
Yes, I think they should be able to move it around on their own as well.
Yeah, you're right.
Cecilia, yeah, we can move it around.
Yeah, perfect.
It's strange because it still says 0% for me in terms of people who have voted.
We aren't allowed to submit until we've answered each of the questions.
Oh, I see. Okay. Maybe just for the other ones, can you, you can just put something random maybe for now, and we'll just focus on the answers for the first one.
We have lots of time, so you don't have to worry about that.
Okay, thank you. You can see 40% voted so far. So maybe I'll give another 30 seconds or so. All right, so we'll take up this answer to the first one. So this is I can see that the majority of people voted for continuous normal voltage without sleep-wake cycling, which is the correct answer in this case. And the reason that is, sorry, 1 second. I can't, sorry. I can't actually see the polling results anymore.
You need to launch. Oh, we don't see the poll anymore.
You don't see the poll anymore.
You
Okay.
need to relaunch it.
Okay. Well, so I actually can't even see what the majority of people voted for. Very strange. So the correct answer for this one is discontinuous normal voltage. And we'll take up the answer. So the reason this one is discontinuous normal voltage is because the lower margin is less than 5 microvolts, as shown here by this bottom blue bar. And then the upper margin is greater than 10 microvolts, which is shown with the kind of upper black bar. So we'll try the second question. Hopefully this works better in terms of the polling. So I think I'm gonna try relaunching the poll. So we'll ignore the answers to any of the other questions. So you can just pick something random for that. And then I'll just focus on the answers that are put in for background practice number 2. All right, so we'll look here. Okay, I should be able to, there you go. So are you able to see the poll results now? So it should be for AEG background practice number 2. I could see that 89% of you voted for continuous normal voltage with sleep-wake cycling, which is the correct answer in this case. This is correct because the upper margin is greater than 10 and the lower margin is greater than 5. And then we have these periods where the tracing gets wider and narrower, and that corresponds to the sleep-wake cycling. All right, so we'll now move on to the third one, and I'll relaunch this poll. So this is AEEG background practice number 3, and you can just put something random in for the other questions. All right, and let me just share the result of the poll. So if we look at AEG background practice 3, I see that 45% of you voted for continuous low voltage, which is the correct answer in this case. And I can see why many of you picked burst suppression. So we'll go through why this isn't burst suppression in this case. So here, both the upper and lower margins are low. And the key difference, though, is from burst suppression and the continuous low voltage activity is the presence of bursts that are more than 25 microvolts, which isn't the case here. We don't see that very high voltage burst activity that you would see with burst suppression. All right, so we're now going to move on to recognizing seizures on amplitude integrated EEG, as well as some common artifacts. So when we're looking at seizures on amplitude integrated EEG, on the AEEG tracing, what we're looking for is a sudden transient rise of the lower margin. So as shown here, you see it very nicely at the beginning that there are multiple kind of areas where there is a rise of the lower margin. We also have narrowing of the background as shown here. So the background looks narrower. Sometimes you could see a rise in the upper margin as well, but not always. And when we're looking at the amplitude integrated EEG and we see something that looks suspicious for a seizure, it's always important for us to look at the raw EEG in order to confirm whether they are seizures. So lower margin elevations on the CFM or amplitude integrated tracing alone without confirmation of this rhythmic pattern on the raw EEG is not enough to diagnose a seizure. So in other words, in order for it to be a seizure, there has to be a repetitive pattern on the raw EEG with evolution of amplitude and frequency. So this here is an example of a seizure, and at the bottom we have the amplitude integrated EEG tracer, the CFM tracing, where you see these elevations in the lower margin on the CFM, as shown here as well. And then this blue line represents the elevation that we're going to focus on that's shown up above on the raw EEG. And you can see how there was this elevation in the background on the right side. And if you look at the red pair of electrodes, you see that there's this rhythmic activity that's shown on the raw EEG as well. So in this case, the elevation of the lower margin on the CFM was a seizure. And here we have another example of a seizure on an amplitude integrated EEG tracing at the bottom where you have multiple elevations of the lower background. If we now focus on one of these as shown here by this blue line, if we look above at the raw EEG, you can see that there's rhythmic activity on the raw EEG seen bilaterally, and that corresponds to this elevation. So in this case, this is also a seizure. So this is our next polling question. So this is going to be AEEG seizure practice number 1. And I'll just launch the poll. So does the AEG show a seizure? So if we look at the poll, looks like the majority of you voted yes for this question. So this was a trick question, and the answer is actually no. And the reason it's no is because a seizure can't be diagnosed based on this AEG tracing alone. You need to look at the raw tracing in order to determine whether this was a seizure or not. So if you look at it here, you could actually see that in this case, this elevation is not a seizure because there's no rhythmic activity on the raw EEG tracing that it corresponds to. So in this case, this is not a seizure. So I'll just launch the poll again. Oh, sorry, wrong poll. So this is AEEG seizure practice number 2. All right, so I'll share the result of the poll with you. So if we look at this AEG seizure practice number 2, 90% of you voted that yes, this is a seizure, and that is correct. The elevation in the background corresponds to rhythmic activity that's seen on the left side as well. So we're now going to move on to look at some common artifacts that we see in the ICU. An artifact makes identifying seizures difficult. And this is why it's so important for us to confirm that the elevation in the background tracing on the amplitude integrated EEG really is a seizure by looking at that raw EEG correlate. Common artifacts that we see in the ICU are HFO, ECG artifacts, shivering, rocking, padding, as well as blinking artifacts. So we have an example in the first case of an HFO artifact, and this can produce vibration of the head with a very kind of profound shake of the body, and the shaking can produce a fine and repetitive pattern as shown here in this figure. And one of the key things to keep in mind is that this pattern is really too fast to be generated by the brain and too fast to be a seizure. Another common artifact that we see in the ICU is ECG artifact on our amplitude integrated EEG machine. And this sometimes can pick up electrical signals that are coming from the heart. And one of the key differentiating features is to match the QRS complex that's seen on this kind of raw EEG tracing with the QRS complex rate that's seen on the patient's monitor. So I think we looked at this example earlier as well, where you see this kind of really chaotic, random artifact on the raw EEG tracing, and this represents movement artifact, which can occur for various reasons in the ICU, such as shivering, jitteriness, handling of the patient, rocking, padding. And this can cause an elevation in the baseline, but when you look at the raw EEG tracing, you see that it's very chaotic and it's not rhythmic. Finally, poor electrode impedance can also be a cause of artifact, and it can cause changes on the amplitude integrated EEG as shown here below. You see this elevation in the baseline on the left side, but when you actually look at the EEG, the raw EEG tracing, you can see that there's an issue here with one of these electrodes, and that's what's caused this elevation here. So we're now going to go through 2 cases to put it all together. So the first case is of a baby with antenatally diagnosed hypoplastic left heart syndrome who had a Norwood procedure done at day 3 of life. The post-operative period was complicated by a prolonged period of hypotension and low cardiac output. And then the bedside nurse noticed some abnormal movements at day 4 of life.
And your electrolytes.
So in the video, you can see how there are clonic movements in the leg, the arm, the shoulder that were not suppressible on the left side. And this is the baby CFM trace. So I'll give you a moment to look at this, and then I will also just relaunch the poll as well. So this will be case number 1, which is number 6 on the poll. Just gonna stop my video. I hope you can still hear me. Getting a message saying internet connection is unstable.
We can hear you.
Okay, great, thank you. All right, so we can take this question up. I'll share the results of the poll with you. So if we look at case number 1, it looks like the majority of you voted for seizures at the beginning, then discontinuous normal voltage. And that is correct. And we'll go through why in these slides. So as you had identified, the bar in the orange, or the section in orange, represents seizures. So you could actually see from the raw tracing that there was an elevation here, and on the raw tracing, you see corresponding rhythmic activity on the raw EEG tracing. And then when you look at this section here, you see discontinuous background, where the lower margin is less than 5 microvolts and the upper margin is greater than 10 microvolts. So that was the correct answer. And just to point out, this is not sleep-wake cycling because it doesn't meet criteria for a normal continuous background. And you can only have sleep-wake cycling with normal backgrounds. So this is the MRI from this patient, and I believe Vanna will review MRIs with you later this afternoon as well. And she'll probably go into this in more detail, but this patient had watershed pattern ischemic brain injury that predominantly affected his right side on the MRI, as you can see here, this in kind of this brighter white area, and you can see it's more on the right side than on the left. So we'll go on to our second case. So this was a baby boy who was born at 32 plus 3 weeks gestation. He was postnatally diagnosed with double outlet right ventricle and interrupted aortic arch, and he had an aortic arch repair at 5 weeks of age. The postoperative course was complicated by neck and vocal cord palsy, as well as sepsis. And at post-op day 10, he had a cardiac arrest lasting 45 minutes in length and needed cannulation onto ECMO. So this is his AEG trace. So this is case number 2 in the poll. All right, so I think the majority of you for this one, yes, 91% voted for a flat or isoelectric trace, which is the correct answer in this case. And this is the patient's CT that showed severe global ischemic brain injury. And I believe Vanna will go into these in more detail later in the afternoon. But just to summarize, before Roy reviews, does a more hands-on review of the EEG machine with you, Amplitude Integrated EEG is a clinical bedside screening tool that can be useful for neurologic monitoring and recognition of seizures in both the NICU and the cardiac ICU. And the key thing is that it's important that bedside clinical staff, physicians, everyone is trained appropriately and really practices using this in order to ensure accuracy of interpretation. So I encourage you to continue to practice looking at as many Amplitude integrated EEGs as you can. And thank you very much for listening.
I have a question for you if you have a moment. I'm just wondering if there's no of the elevation changes on the AEEG, but there is rhythmic movement on the full, like the raw EEG, could that still be a diagnosis of a seizure?
Yes, it can. So as I believe we discussed at the beginning, Amplitude integrated EEG is good for picking up about 70 to 75% of the seizures, but it can miss some seizures, including ones that are very brief. So for example, if it's a very short seizure, you probably won't see an elevation in the baseline. Like if it's a seizure less than 15 seconds, each of those lines corresponds to 15 seconds. So you actually won't see an elevation in the baseline just because it's so short. So that's why Amplitude Integrated EEG is a really good screening tool. It's one that's good for us to use in babies who we think are at high risk. But if you're seeing changes without elevations in the background, you do have to move to something more diagnostic, like a CEEG.
Thank you.
You're welcome.
Any other questions?
All right. Well,
We have one comment that says great lecture. Thank you.
Thank you. So Cecilia, I've made you host again.
Okay, thank you.
Thank you.
Our next two speakers are Amrita Vilwin, who's a EEG technologist in the neurophysiology and EEG lab, and the manager, Roy Sharma. And they're going to take you through a live demo of the EEG system and how to make notes on the system and looking at the electrodes.